I will be talking mainly on hypothyroidism and to brief us because we all are learned and you all are seniors where so since so many years you are practicing. So then I thought ki let us collect all the guidelines from all parts of the world. And that's why I have gone through all these guidelines, right from Latin America, NIH, Endocrine Society, British, Royal College, Royal Australia, America, Asia Oceania, NICE, and our own FOXY and European Thyroid Association. And then this presentation is made, and then I realized ki for our Indian subcontinent, what is needed and what is to be done. First is the word for screening. We all know that there are two types of screenings. One is high risk based screening, and another is universal screening. So it is the past when we were being told to do the case based screening. So that means these are certain 12 points. Okay, if there is a history of hyper or hypothyroid disease, family history of thyroid disease, goiter, antibodies, anemia, high cholesterol, hyponatremia, etc. Only in such cases it was told that we should screen the thyroid disorders. But the first line itself says that it is past. And then so many studies were there, Wang, Goel, and even our Vaidya et al. And everybody showed that they compared actually whether universal screening is important or selective case-based screening for thyroid disorders in pregnancy is important. And then they said that, see the first line, almost 81% of the patients they missed with hypothyroidism in pregnancy when universal screening was not done. It is remaining, all the studies show somehow same. Some say 30%, some say 55%, some say 40%. That means major chunk of the patient is getting missed because in many parts universal screening for thyroid disorders is not done. So this was the final, and this supported for the advocacy of universal screening. They did one, two, three, all cat studies, and they said that case-based screening can miss up to 49% of the pregnant women with thyroid dysfunction. So universal screening is recommended. And even the Indian Thyroid Society, along with FOXY, ESI and all, they said that yes, in India, all pregnant females must be screened at first antenatal visit by measuring TSH level. The evidence level was 2AB. So that means we all should do universal screening. That means all pregnant women should be screened for thyroid disorders. That is a one line statement. There is a hypothyroidism when we see there is a great variation, geographical variation from 12 to 40%. Fortunately, I was a part of the study which was done in almost three-fourths of the whole nation in all states. We have found out that in Telangana, Karnataka, Western Maharashtra, and in Jammu Kashmir, the incidence of hypothyroidism in pregnancy reaches up to 40 to 44%, while in other parts it ranges from 12 to 20%. In my own clinic, which is based in Western Maharashtra, we did a study of almost 850 women where we found out that 24% is the incidence. And again, when we went into the depth, what I did, I did the geographical markings because it was a previous study or it was previous teaching. Usually, hypothyroidism lies near the ghats or near the parbat, near the all this region, and it is never there on the banks of the river or it is never there on the banks of the sea. It was a previous teaching. But alas, when I did the such type of study, कि Baba, where do you stay, which drinking water do you drink daily, what is the source, and etc. Then there was havoc, and havoc results. Almost 90% of the hypothyroid patients, they were from the bank of the river. When they did the study in Konkan, almost in Konkan we are not expecting the hypothyroidism because those are fish eaters. But again, our Konkan study showed that 26% is the incidence of hypothyroidism in pregnancy in that given population. So from it comes. And then when I went into the details, I will come shortly in the etiology about it. Before that, we all should know subclinical hypothyroidism and overt. We know normal free T4, and when TSH is more than 2.5 but up to 10, it is subclinical, means it is just a biochemical evidence, and actually patient doesn't have any hypothyroid symptom. While overt is a symptomatic thyroid hormone deficiency, the free T4 might have gone low and TSH may be more than 2.5 to 10, and any TSH more than 10, we should treat that patient like a overt hypothyroidism. So if we keep these three lines, then our subject is very easy to understand. So any TSH more than 10, patient is overt hypothyroid. Suppose TSH is between 2.5 to 10, just do free T4 of her, and we can classify that patient as either subclinical or overt. Somebody will say, कि अरे your opening remark was कि subclinical as well as overt should be treated. And why you are classifying again? Because again, it is the dose of the thyroxine hormone in the management of subclinical and overt may differ. And that's why we want to classify that patient. Most common causes everybody knows. These are, I will say, these are the usually given that chronic thyroiditis, autoimmune thyroiditis, Hashimoto, subacute, radioactive, thyroidectomy, iodine deficiency. But do you know Hashimoto's disease is the most frequent cause in industrialized nation. But again, as I was telling, when we have gone into depth of our mapping of our hypothyroid patients, we have found out that sugarcane industry pollutants in the drinking water is one of the major cause for hypothyroidism. And it is not only sugarcane industry pollutants, but all hydrocarbon emitting industries which are giving all their pollutants into the drinking water are the main thing. And those patients, they mimic the condition like Hashimoto. And that's why, as I said, on our banks of the river, Krishna, Varna, and all, where there are so many sugarcane industries, almost 10 to 11 in one taluka. So we have high hypothyroidism. And iodine deficiency, I will say it is the most common textbook cause because WHO has already declared our India as an iodine sufficient state because almost fortification. And even if we go into the depth of asking what is their eating source, drinking source, etc., then usually it is fortified with iodine. So iodine deficiency, I will not say is the most common cause, but it is the autoimmune thyroiditis, and secondary, it is the thyroiditis secondary to the pollutants is the main cause for hypothyroidism in pregnancy nowadays. Now there were so many the confusions about the levels. What should be the level? The first and foremost thing we all should keep in mind. Please do not do T3, T4 in pregnancy at all because they will vary. And even you may get a report that T4 is high but TSH is normal, or T4 is also high, TSH is also high. So we'll not go in those confusions. Simple thing, screen all patients with ultra sensitive TSH. That's it. So what will happen? Number one, we'll come to know whether my patient is at risk. screened, right? So let us say 40% of the patients, they may come with some abnormal TSH level. 60% patients have gone. So only in those patients we can do free T4. So unnecessarily there is no wastage of the natural national resources. So only those patients we will do free T4 to classify and further help the treatment. So that should be the sequence. Screening with ultra-sensitive TSH and classification should be with free T4. Now somebody will say, Are what about antibodies? I'm going to come to that later on. Now there are so many confusions, so many guidelines. Forget about it. In India, we have accepted, NHM guidelines have accepted, FOXY has accepted, Indian Thyroid Society has accepted. Then who are we to say that, no, 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 we use these guidelines, we use that guideline. Forget about it. National Health Mission, FOXY, and Indian Thyroid Society, IAP, all have agreed to use this ITS guideline, that is first trimester TSH 2.5, means zero point 0.1 to 2.5, second trimester zero point 0.2 to 3, third trimester zero point 0.3 to 3. So these are the cutoff for TSH. So I repeat, first trimester 0.1 to 2.5, second trimester 0.2 to 3, third trimester 0.3 to 3. So if the level is more than 2.5 at any time during the pregnancy, or as 3 in second and third trimester, FT4 level should be checked to determine overt or subclinical. If FT4 is low, overt hypothyroidism. And now my statement is no need to check antibody levels at this stage at all. It's a very clear statement. So there is no need to check the thyroid antibodies. Let it be our peroxidase antibodies, antithyroglobulin antibodies. Forget about it. Here we are talking about screening hypothyroidism during pregnancy. We are not talking a case of recurrent pregnancy loss. We are not talking a case of infertility. So please, we have to keep this in mind. So for routine cases, start with ultra-sensitive TSH. If it has deranged, free T4, and that's it. Why we are worried? It is because these are the three P's we have to keep in mind. There are three P's, and again, fourth P has been added by one of the good North Indian study. So purposefully, I have kept here three P's, but there are fourth P is added. Untreated hypothyroidism. It will increase the maternal risk of first pregnancy loss, second preeclampsia, third preterm labor, and what is fourth P? PPH. Again, postpartum hemorrhage, when the audit was done, then it was found out that the maximum of those patients, they were not only having hypertension, preeclampsia, but maximum patients, they were having again hypothyroidism. So we have to keep in mind, yes, hypothyroidism has something to do with the postpartum hemorrhage as well. So these are the four P's. So if we treat the hypothyroidism with proper dosages of the L-thyroxine in a proper way till delivery, then all these complications, they will minimize like anything. Again, as Madam was mentioning, yes, these are not only maternal complications, but there are fetal complications as well. And what are they? Low birth weight, again FGR, then children with significantly lower intelligence. Definitely, it has been proven, and very important. The last third lines I want to draw attention because there is one part called as Medghat in our northern Maharashtra. Similar parts are there in Jharkhand. There are certain parts which are there in some parts of Telangana as well, where the maternal hypothyroidism with iron deficiency that has caused the increased risk of congenital cretinism. That means growth failure, mental retardation, and other neuropsychological defects. So when we are talking as a national person, then yes, we have to keep in mind. And again, here I want to draw attention that we have a good study where, madam, we have seen that hypercholesterolemia, iron deficiency, and hypothyroidism, they go by hand in hand. So that is there. When in our Indian population, whenever I see a hypothyroid patient, I request her and I get done her lipid profile, and we have seen that there is hypercholesterolemia. Again, same population has severe iron deficiency. So that means there is all these things are connected, and if we bind these three things together, definitely how which population will come up, we have to think on that. Decision of treating subclinical hypothyroidism, I have purposefully cut is it was debatable. So now nobody should say कि नहीं हमारे जमाने में ऐसे होता था and we use no nothing like. We have to treat even subclinical hypothyroidism. That is the message from this slide. Now, what is the treatment? Oral levothyroxine is the treatment. Khatam. That is a one-line statement. Oral levothyroxine is the treatment. फिर ये खाओ वो मत खाओ सोयाबीन मत खाओ फिश खाओ nothing like that. Oral levothyroxine is the treatment. Rest are supplements. So when patient is overt hypothyroidism, little higher doses are required, like 50 to 75 microgram per day. While for subclinical hypothyroidism, we may start with 25 to 50. Foxy guideline, NHM guideline says 25, while Indian Thyroid Society guideline says start with 50. So it is better to write कि subclinical 25 to 50 and for overt hypothyroidism 50 to 75 microgram daily. Now the third variety is there. Third variety is known case of hypothyroidism now become pregnant. Now what will happen? We have to increase the dose by 25 to 50. Ideally 25 mcg is recommended. That when there is known case of hypothyroidism, now she becomes pregnant, increase the dose of L-thyroxine by 25 depending upon again TSH levels. Now, purposefully I have kept this slide like this. When to prescribe? Preferably early in the morning. Now, we tell the patient that eat that tablet fasting. But again patient says कि सर मैं चाय के साथ लूँ फिर चाय खाने के बाद कुछ खाऊं फिर ये मैं खारी खाती हूँ मैं बिस्किट खाती हूँ. So what is the ideal recommendation? I have discussed it with the pharmacology people, endocrinology people. The simple line they told that after thyroxine tablet, at least for 1 hour, nothing to be taken. Simple line. So I tell my patient, as soon as you get up in the morning, with a sip of water, you take that thyroxine tablet, start your household work, and after 1 hour, go for your tea, coffee, and something. Simple idea. Then one patient asked me, sir, can I take it in the evening? No problem. But you have to take it at 6 or 7 o'clock so that after 1 hour, you should not, within 1 hour, you should not go for dinner. If you keep that in the mind, there is no problem. So simple idea. Preferably early in the morning and after thyroxine tablet, at least for 1 hour, nothing to be taken. When to check the TSH? Clear guideline, NHM guideline, Foxy guideline, ITS, everybody says after 4 weeks of the initial testing. When we have started the treatment. That we have to keep in mind. If you ask me about screening, I will say ultra-sensitive TSH in each trimester. That is for screening. But when we have the case of hypothyroidism, we have started the treatment, when to check after 4 weeks. When to reduce the dose. So on papers, I write like 0.1 to 2.5 in the first trimester. And I write there is a down arrow. If your level goes below 0.1, I will reduce your dose by 25. If your level is still more than 2.5, I will raise the dose by 25. And if the level remains between 0.1 to 2.5, I will keep the level same. So it is a simple idea that you can measure. So how to reduce the dose? If TSH has gone down 0.1 in first, 0.2 in second, and 0.3 in third trimester, reduce the dose by 25 mcg. So somebody will ask, अरे she was put on 25, तो वो क्या करेगा? 25 minus 25, I will take her to 0. If she was on 50 minus 25, I will take her to 25. Simple. When to increase the dose? If the TSH level has gone high or still more than 2.5 in first trimester and in second and third more than 3, then definitely I will increase the dose again by 25 mcg. Sudden changes are not recommended. Then you will say कि अरे ऐसा कोई नहीं करता. I have a record of almost 100 doctors where आज 50 था, कल एकदम 100 हो गया, परसों एकदम 25 हो गया, क्योंकि वो TSH का लेवल इधर उधर हो रहा है. No, that's wrong. 3 things we have to keep in mind. No sudden changes, either in increment or in decrement. Second thing, repeat TSH from the same lab. Third thing, use the same kind of L-thyroxine. Here, I am sorry to say, but purposefully I will take the names of the companies, means the brands, but if this is just for giving the example, it is not the advertise. If you have started patient on L-troxine, please continue on that. If you have started Thyrox, please continue on that. If it is Thyrox, please continue on that. आज Thyrox लिख दिया, कल L-troxine लिख दिया, that's wrong, because these are hormone preparations and we should not change the hormone preparations. That's very simple guideline of the endocrinology. So that we have to keep in mind. What is not to use or not is recommended? Try iodothyronine, desiccated thyroid or any other market preparation on the name of Ayurveda, homeopathy, naturopathy, or even some of our seniors have recommended कि use this desiccated thyroid, etc. Wrong. Postpartum management. Simple. This is very important. Each line is important. Postpartum treatment will be continued at the same recommended dose for those where we have started the treatment with TSH more than 10. Very clear. Means जिनका TSH 10 से ज़्यादा था और हमने उन्हें ट्रीटमेंट शुरू किया, उनका उसी डोज पे चालू रहेगा इवन आफ्टर डिलीवरी. Simple. Second, for the woman between TSH 3 to 10, the treatment has, that means for all subclinical hypothyroidism patients, if the dose is up to 25 microgram, stop the treatment. We can discontinue the tablet. If dose is high, like 50, 75 for subclinical hypothyroid, we have to reduce the dose by 25 as soon as after the delivery. And then we have to check the TSH after 42 days, and depending upon the non-pregnant level, we have to continue the treatment. So very simple. And third category, woman was diagnosed, means she was known case of hypothyroidism, now become pregnant, and in pregnancy, the dose was increased. Maybe from 25 to, it has gone to 75. Then what is to be done? Then, after delivery, we have to resume the pre-treatment, pre-pregnancy dose, and after the delivery, till 42 days, and after 42 days, check TSH and further treatment to be done accordingly, depending upon the non-pregnant level. Even it is beautifully described in our NHM guidelines. So I want to repeat this slide.
Yes,
So
I was requesting that you should repeat. I'm glad that you decided yourself.
Yes, madam. I will repeat this slide. Number 1, patient was subclinical hypothyroid. She was on the dose of 25 mcg. Discontinue the treatment just after the delivery. Second, patient was on L-thyroxine, but she was diagnosed as TSH more than 10. That means overt hypothyroid. Or even all overt hypothyroid patients continue the same dose of L-thyroxine. Now there is third category. Known case of hypothyroid, now become pregnant. During pregnancy, dose was increased. As soon as after the delivery, take her to pre-delivery doses and repeat TSH after 6 weeks postpartum in all cases. But now that patient is delivered, so depending upon non-pregnant levels of TSH, we have to manage further thyroid. And this is how we will reduce the unnecessarily treatment of L-thyroxine postpartum. Otherwise, what is happening? Many of our colleagues are saying that एक बार थायराइड का गोली शुरू हुआ तो आपको लास्ट आखिरी तक लेना है. No, it is not like that. So that we have to keep in our mind. Now somebody will ask, what about the baby? Is there necessity to do the levels of baby? The answer is no. Because now we are dealing with the cases of hypothyroidism. So ideally no, but where the doses are more than 100 of thyroxine, one may consider seeing the levels of the baby. Or if the area is endemic zone, one may consider the thing. But otherwise, in hypothyroid mothers, it is not recommended. Checking the levels for the baby is recommended in hyperthyroid patients because there is a risk of transmitting two types of antibodies. One must know that in cases of hyperthyroid patients, there are two types of antibodies. One are inhibitory and one are stimulatory. So we do not know which type of antibodies are passed from mother to baby. So to check that, we have to see the TSH levels. Suppose if the stimulatory levels have gone, baby may have hyperthyroidism to hyperthyroid mother. And if the inhibitory antibodies have gone, then baby may have hypothyroidism to hyperthyroid mother. Likewise. So simple one line. It is not like that कि इधर डिलीवरी हुआ कि कॉर्ड ब्लड ले लिया और TSH भेज दिया. Wrong. But in endemic zones and where the doses of the L-thyroxine are 100 or more than that, we may check, but again, not in the first week of the life. That we have to keep in mind. So simple, if we keep, as मैं मैडम से हमेशा ये करता हूँ कि मैडम ने मुझे वो जो एक आशीर्वाद दिया है और सजेशन हमेशा दिया है कि गोरख बेटा हमेशा एक स्लाइड बनाओ कि जो हमें सब लोगों को, मुझे भी, कि सिंपल कुछ दे दे. तो दिस इज वन स्लाइड. स्क्रीन and diagnose with TSH. So I will add here screen and diagnose with TSH. Classify with FT4. Monitor with TSH every 4 to 6 weeks. There is no need to do free T4. In cases of hypothyroidism for monitoring, we are wasting national resources. Unnecessary money is going on. And that FT4 is not going to change our dose. In cases of hypothyroid patients, the dose will be titrated only depending upon TSH levels and treat with L-thyroxine. So again, it is a jhamela of the thyroid. So I repeat, screen and diagnose with UTSH, classify with free T4, monitor with TSH every 4 to 6 weeks, and treat with L-thyroxine, and that's it. Now, this is a concept which I wanted to put forth. Madam, when maybe in 2015 I put forth this concept, and this was pure my concept because yet it has not come in the textbooks. And this is a concept of gestational hypothyroidism. Then you may say, "Arey, ye kya hai?" Yes. I have seen that in many of our Indian population, our Indian women, they are with, now all sentences, they are very much, I am framing with very much caution because I am speaking with all you learned leaders. Our Indian population, many of our women, they are with low thyroid reserve. It's a very important concept. Second, many of our women, they are with positive antibody status, but they are euthyroid. So these are the two important concepts. And these patients, when they become pregnant, they go in hypothyroidism. And that's why what is happening, we are doing, many of us are doing TSH only in first trimester, levels are normal, we say that I have screen, khatam. But mind well, these patients, our Indian patients, they go in hypothyroidism in many instances in second or third trimester. And that's why we are getting late IUGRs. Because along with anemia, along with hypoproteinemia, our patients are going with GDM in IUGR. That is a problem. So, I will read this purposefully, word by word. A new insight and a terminology I want to introduce here in the form of gestational hypothyroidism. We all agree that pregnancy affects the functioning of the thyroid gland. It causes 10 to 40% increase in the size of the thyroid gland as well as 50% increase in the production of thyroid hormones, namely T4 and T3. The pregnant women who are initially euthyroid but having limited thyroid reserve and or with iodine deficiency can become hypothyroid during the latter stages of pregnancy. Same is true about the pregnant euthyroid women who are thyroid autoantibody positive, as they have increased the propensity to develop hypothyroidism later on due to the destruction of the gland tissue due to autoantibodies. And all such women, they will require TSH monitoring throughout the pregnancy. And that's why screen every women with TSH in each trimester. That is the concept of gestational hypothyroidism. So, thank you very much for patient listening. Thank you very much for giving me this talk on hypothyroidism in pregnancy. And I'm open for the discussion because I know that there are many concepts which I have put in a rebellious manner. There were so many statements they were put on rebellious manner. And some may say कि अरे हम तो ऐसे नहीं करते, और many guidelines are saying or they are differently using different levels. Then what is to be done? So thank you very much for patient listening. Thank you very much, madam.
Thank you,
I think
Dr.
it
Gaurav.
was Gaurav, wonderful, wonderful, wonderful. Wonderful is a small word.
Ma'am,
Yes.
your comments.
Sir, I have a question to you. Can I ask a question?
Yes.
Please, ma'am, please go.
So, sir, what is the role of anti-TPO antibodies, and when it has to be done? You have
Yes.
not mentioned it
Yes,
anywhere in
purposefully.
the
Yes, madam.
presentation.
Purposefully. Yes, madam.
Yes, so I
When
would
we
like to know.
yes. Number one, when we are saying screening of hypothyroidism or thyroid disorders in pregnancy, it has no role.
Okay.
Number two, when we have a patient of recurrent pregnancy loss,
Okay.
definitely there is a role of thyroid autoantibodies.
Okay.
Then, not only anti-TPO antibodies, but anti-thyroglobulin antibodies to be done.
Okay.
So that's very important.
Okay.
When we have unexplained pregnancy losses, even maybe full-term loss, even in those cases, along with antiphospholipid antibodies, we have to do antithyroid antibody. But
Okay.
per se, routine, because I have seen many our colleagues treating the anti-TPO antibody positive status by using the steroids, aspirin, and whatnot, which has no meaning. So, and it is proven beyond doubt, and it has come in the guideline. Even in Indian guidelines, it has been written that all these things are to be done only in recurrent pregnancy loss cases, not routinely.
Okay.
Over to you.
So it means we have to give the treatment even if the TSH is 3.5 in first trimester
Yes, madam.
without doing
Ideally,
antibodies.
yes.
So that
Because
message is loud and clear.
loud and
Right.
clear, loud and clear.
Thank you. Thank you so much.
Thank you, madam.
Thank you, Dr. Kiran. Dr. Vandana?
Yeah, wonderful as usual, Dr. Gorak. And one thing I would like to add that the endocrinologists, they say that thyroid hormone is a hormone with a long life, half life inside the blood. So you can do a weekly reduction of the doses also, and weekly increments also, and increments to the tune of 30% the moment you get to know in an established case that the patient is pregnant, and the easiest way to calculate is just double the dose on 2 days of the week, twice a day. And then you can redistribute the dose according to the TSH levels whenever you do it. And same way in the decreasing fashion also. You
But
can
only
decrease
that
the dose by 30%.
that is agreed, but only in cases of severe overt hypothyroid patients.
Yeah, severe overt hypothyroidism.
Only
Yeah,
in severe overt. So
yeah, yeah.
again, that population will go to 10% of the total hypothyroid patients.
Right.
But for 90% of the hypothyroid
You
patients,
mean to say gestational hypothyroidism?
yes, the
They
simple
would.
thing is for
Okay.
subclinical, better to start with 25 to 50, and for overt, start with 50 to 75, repeat after 1 month, and there is no problem.
See, those they say it depends upon 1.5 to 2.5 micrograms per kilogram.
Yes.
So we can always recalculate, because at times we have obese patients.
Correct. But
The dose has to be
again, the problem is, yes. So better to, that's why we have kept key, better not to complicate. And that's why
right.
when we simplify it for the nation, simple is 25 to 50. So as you rightly said, for obese 50, for routine BMI more than BMI less than 24, it is better to use 25. Same is about overt. So it is better. Otherwise, even many of the companies they have come up with 12.5.
Yes.
Yes, even 37.5,
Yes.
That is
88
to
you must have.
titrate the doses. That is
Yes,
to
that is for
titrate
the
the doses.
titration. They have come up
Yeah.
like that.
Right.
That is
Absolutely.
dose titration.
That
Yeah.
is those titration. They have come up with the same tablets.
Yes.
Right.
Dr.
Right.
Gorak, can I
The
ask one
tablet
question?
should never be broken. That is the one thing. It
Yes,
should
madam.
never be broken. Either you replace, in case you are changing the dose, either replace or you add.
Yes,
But
I
don't
will add.
break the dose. Yes, if you have 50, you want to reduce to 25, don't ask the patient to take it
Half
half
tablet.
every day. You can do it alternate day. Take 50 alternate day, that would do, but not breaking it into half.
Yes. I will add that line in my presentation. That do not
Right.
break the tablet. Thank you very
Never
much.
break the tablet. Never break the tablet.
We will take Archana's comment later. We'll ask Shakuntala to make comments.
Thank you very much. Dr. Gorak, it was a wonderful presentation. I have just one small comment, and that is there are women who are not able to conceive. And when we do a preconceptual workup, thyroid comes as a major factor.
Yes.
And once you start treating the thyroid, the ovulation may take, proper ovulation correction may take up to 4 to 6 months as well. So we
Yes.
have to counsel the patient that
Yes.
they have to be, like patient about it, and the apprehension should not rise. Otherwise, what happens? Everything is corrected, and patient is so tense that she fails to conceive. That is one thing. Secondly, these thyroid patients should be supplemented with calcium as well.
Absolutely.
Definitely.
Great.
Iron also.
Otherwise, your presentation was absolutely complete.
Yes.
Thank you very much. Thank you.
Absolutely, madam. So I want to do the two comments. Madam, you are absolutely right. The first part, what you said, in
Dr.
cases of
Gorak, I will add on.
yes,
Add on here
please.
before you make a comment that all these patients are hypothyroid, because there is a combination of anemia and hypercholesteremia in such patients.
Correct.
They should not only supplemented with calcium, they should be.
मैम वॉइस
मैम,
मैम आप म्यूटेड है आपकी वॉइस नहीं है
They must be supplemented with iron also,
Yes.
along
Right.
with calcium.
right
Madam,
right.
as you rightly said, again here I would like to add or sum up on this note. Okay, we have to use calcium given vitamin D3 and iron to all these patients. And as madam has rightly said, कि during the infertility workup, hypothyroidism is affecting like anything,
Correct.
like anything. So because yeah, so in all cases of infertility, we must do the TSH levels, and depending upon that, we have to go ahead. So that is true, absolutely right.
And
Sir, in
maybe somehow it
RPM,
is
the
linked to
management is same or
prolactin levels as well. So
Yeah.
that is the way, that is the reason
Of
why we
course,
do not
we
get
have apart
estrogen.
from the other workup, the management, the detection and management of hypothyroidism is very, very important. Even the subclinical hypothyroidism should be managed.
Absolutely.
Absolutely.
And that's, madam, and that is why I have kept that concept of gestational hypothyroidism. Means these are the patients who are with limited thyroid reserve. So they are on the verge that they may get into hypothyroid at any time as soon as they become pregnant. So you are absolutely agree.
Sir, Dr. Gorak, in recurrent pregnancy loss, we do anti-TPO antibodies. So management remains same according to TSH level or it differs?
The management level remains same depending upon the TSH level. Only thing is कि when they have, suppose the cases of recurrent pregnancy loss, and now she is only anti-TPO antibody, but she is euthyroid. फिर क्या करे? So in such case patients, then we may have to check for the cross reactivity of other antibodies. We have to check for plus, we have to check for even ANA, and if association comes, then probably along with aspirin, along with steroids, then we may have to take that further case. But suppose if that patient is anti-thyroid antibody positive and hypothyroid, then depending upon the doses or levels of the TSH, we have to manage or titrate the dose of L-thyroxine. That is a very clear message.
डॉक्टर अर्चना आपके कमेंट्स
Madam, very nice, Dr. Gorak, as such very complete talk, I must say. And what I wanted to ask or say, you have already said. One thing I only want to say and ask rather, in perioperative and the preoperative patients, sometimes they are not tested. And they don't tell that they were taking in some this thyroid treatment, and in the emergency you are dealing with such patients. So what else we need to do?
Correct,
Because
madam. You are right, madam. Okay, many a times it happens, and it either way it happens. Suppose if undiagnosed hypothyroid patient comes in front of us, then there is a delay in the clearance of propofol
Propofol,
and
right?
rest, especially propofol, and all the even midazolam and all many no, our anesthetic drugs. So whenever we are taking any patient for any operative, at least we must ask if she is from endemic zone, check for TSH, or we must take the proper history, family history of the hypothyroidism. But again, it will be okay. But the problem is with hyperthyroidism. And if suppose undiagnosed hyperthyroid patient, if she comes in front of us, then there is a very havoc situation of thyroid storm is there, and that is very dangerous. And even I have seen one patient when I was doing anesthesia in 2001. There was a one patient of thyroid storm, and she was undiagnosed. And when some money, the adrenalized something was used, and she went into the thyroid storm. So, but again here I will say, and madam will agree that baseline pulse, baseline pulse will diagnose whether my patient has hyperthyroidism or not. If consistently the pulse of the patient is more than 100, consistently we are seeing that her palms are moist when we are checking her. Consistently we are saying that she is very much warm and her weight is reduced. We must arise a suspicion in our mind, should I do her thyroid levels before taking her for any operative? and probably that thorough clinical examination may prevent these complications. Over to you.
Dr. Chitra, you want to make any comment? Dr. Chitra, Dr. Umarai?
Uh, can you hear me?
Yes,
That was
yes.
an excellent talk by Dr. Gorak. So I just wanted to ask one thing from doctor, that you said to titrate the dose of levothyroxine based upon the TSH level. Can you just briefly tell us what should be the dose of thyroxine depending upon the TSH level in pregnant and non-pregnant women?
Okay.
Roughly.
Simple. For subclinical hypothyroid patients, we have to start with
Dr. Gorak, I just want to introduce you. Dr. Chitra had been Professor Emeritus from Lady Harding Medical College, and she had been my colleague from Lady Harding.
Namaste. Right. So
Thank
a
you,
simple
doctor.
4 lines. For subclinical hypothyroid, we have to start with 25 to 50. For overt, we have to start with 50 to 75. After 1 month, we'll check TSH. Now, if the TSH is within normal range, please continue with the same dose. If the TSH in first trimester is less than 0.1, or in second trimester less than 0.2, or in third trimester less than 0.3, we have to reduce the dose by 25. If the TSH is more than 2.5 in first trimester or more than 3 in second and third trimester, increase dose by 25. So whatever increment by 25, whatever decrement by 25, it is a simple formula, no complications, and patient gets titrated and treated very smoothly.
Thank
Over
you,
to
doctor. Thank you.
Thank you, madam.
Uma, you want to say something, Dr. Umarai? Please. Uma, unmute yourself. Yes.
Yeah. Actually, Gorak, are you a teacher or no? First, that. You're really beautiful, you teach. To a teacher
She's a
also. So
primary school teacher.
huh?
Primary school teacher.
Madam
Okay,
always
yeah.
says,
Because
Madam always,
Could he
he
come and
has
visit
taught
me?
professors from Chitra, myself, both, and it was really wonderful. It is
Doctor,
become so clear to me. I
Doctor,
can't explain
he
it.
reminds me, ek mere saath, doctor, when I finished my medical college and I started working for adolescent health and all about 30 years back. This boy, he tells me before we go for a meeting with the principal and we are 20 people. He says, "Doctor, मुझे ये बता दो आप वहाँ बोलने क्या वाले हो मेरे सामने?"
डॉक्टर रेणु सिंह
I
आप अपना म्यूट
always,
कर लीजिए
I told him, what
म्यूट
is he
लीजिए
asking? He said, नहीं डॉक्टर साहब, अगर आपने बड़ी क्राउड में बोलना है तो कम बोलना है और कुछ ही पॉइंट्स देने हैं. What I like about Dr. Gorak is that he does not complicate at all, and whatever he makes solid statements. And आप उसको ही just follow कर लो, सब कल्याण हो गया सब. आप अभी thyroid खत्म हो जाए, then we will take his comments about severe PT. Uma, you want to say something before we change the topic? Unmute.
Madam, unmute please. Unmute please.